My name's Anne-Marie Hughes, and I have with me today Dr. Ben Stanger.
Hi, Anne-Marie. It is nice to see you today. Thank you so much for doing this. I'm Ben Stanger. I'm the Hannah Wise Professor in Cancer Research at the University of Pennsylvania, and I'm the director of our Pancreatic Cancer Research Center.
Thank you. Ben and I know each other very well. I have been treated at Penn myself for oncology, and they have served me very well in my many years of survival. So Ben, tell us a little bit about why you got into the field of pancreatic cancer.
Sure. So I'm a physician scientist. I did a PhD in genetics and immunology and postdoctoral work in developmental biology, how the pancreas develops. So my interest in pancreatic cancer actually came from the clinical side, where I had a patient encounter as a medical student. And that was a gentleman in the prime of his life who was diagnosed with metastatic pancreas cancer. And this was in the 1990s. There was really very little that we had to offer. And it struck me as so unfair and so horrendous that I sort of had this thought that I'm going to have a laboratory probably one day, and I want my laboratory to make progress in the face of this disease.
I've been asking a lot of people what their mantras are in life. What's yours?
So I think my mantra is to make it count. We're on this planet for a really brief period of time. And I feel like it's important to find some mission or some goal and to use that time well to make the planet a better place.
That's a great mantra. I love it. And I think it serves you well as a researcher as well.
It does. Yeah.
So in research for pancreatic cancer, tell me a little bit about latest developments for an early detection for this cancer, because that's really the crux of the issue right now.
Early detection is really critical, as you say, and it's really a tough problem. Pancreas is located deep inside the body, so it's not straightforward to be able to examine that part of the abdomen for the development of a cancer. So we don't really have the types of screening tests we do for colon cancer, like a colonoscopy, which is one of the things I do clinically, or mammography. There's been a lot of work over the last couple of decades to try to find a blood test, so something like a PSA that we use for prostate cancer. And it's just turned out that it's been problematic. There are markers in the blood, but pancreas cancer is relatively less common than other cancers, and the blood tests are relatively insensitive. So it doesn't yet make sense to use any of the blood tests that we have to screen people on a population level. And our group here at Penn and many other groups are working hard on this to try to find other markers, other things in the blood that a very small early cancer might release that can be used in combination to try to detect the tumor. What I would say is where we stand at present is there are a couple of clinical features that people should pay attention to. For example, the new onset diabetes is associated with an underlying pancreatic cancer. That by no means means that everyone who has a diagnosis of diabetes in their 50s or 60s has a pancreas cancer, but the risk is higher, and that warrants some thinking about that. People who have inherited cancer syndromes, particularly breast and ovarian cancer syndromes, or have a family history of pancreas cancer, that can indicate that there's a gene that runs in the family, in particular genes that fall into the BRCA family of genes that would prompt some genetic testing and potentially some surveillance.
In terms of the blood test, you know that we often use CA19 as a marker, but it's not a perfect marker.
Right.
Why is that? And what is CA19?
So CA19-9 is the full name of it. It's a glycoprotein which means it's a sugar-coated protein that isn't really made by cells normally, but in a large percentage of cancers, and in particular pancreas cancers, the abnormal cells start making and releasing this protein into the bloodstream. Um, it's an inadequate test because in general, the cancer has to reach a certain size for it to be making enough of this protein for us to be able to detect it. So for example, it's a useful test for monitoring response to therapy. For instance, if someone has a large cancer and they're treated with chemotherapy and the tumor responds, you can see the CA19-9 level go down, and that tells you you've gotten rid of some of the tumor mass. And then by following that blood test, if the CA19-9 starts to rise again, that's an indication that the cancer's coming back. But for those early, small cancers that we want to find where we could still do surgery, the levels are just generally not high enough. And that's why the next generation of blood tests that we're working on might include CA19-9, because in some small tumors, it probably would be released to a high enough extent. But we're looking to match that with other things that small tumors might release. DNA, specific DNA sequences, for example, or other molecular markers from those small tumors.
What are some exciting developments you're seeing in research, and how are you collaborating with other researchers out there to come up with a solution?
Research community around pancreas cancer is really one of the most cohesive research communities I've ever worked with. Immunotherapy is just an exciting development in cancer in general, harnessing the immune system to be able to recognize tumor cells as foreign. To date, immunotherapy hasn't worked so well in pancreas cancer the way it has in other types of tumors. It's my belief that it's just a matter of time and understanding the details. Every cancer is different, every type of cancer is different, and every individual cancer is different. And so the tricks that a cancer uses to outsmart the immune system is going to differ from tumor type to tumor type and from individual tumor to individual tumor. So the way forward is to just understand those tricks to a greater and greater degree of fine resolution. And through that, I am very optimistic that we'll be able to find drugs that can energize the immune system against pancreas cancer. The other area that's, I think, quite interesting and exciting is the field of cancer metabolism. So all cells need metabolites to grow. Cancer is the same. In fact, it needs more of those because it's growing. One of the unique things about most pancreas cancers is that they have to find other ways to get those nutrients than the standard way. The standard way would be through blood vessels. Just in general, tumors recruit more blood vessels to make them grow better. But pancreas cancers have fewer blood vessels than most cancers do. So they've come up with all these alternate strategies for being able to get what they need to be able to grow. And so as we know what those strategies are, those create opportunities for therapy, because if the tumor needs gene X or gene Y to be able to assimilate those nutrients, then those are perfect targets because the cancer needs it, but our normal cells don't. And that's another area that I think we're making progress on.
What are you grateful for?
I'm grateful for my health and the health of my family. I think that's so important. I'm also grateful to be working here at Penn, actually. I really like the environment here. It's very collaborative, and I enjoy coming to work every day. So I think it's a gift.
Well, I'm grateful for people like you.
Oh, thank you.
Dedicated
Thank you, Emery.
your lives to finding solutions for people like me.
Thank you, and I'm inspired by the community of survivors and people who are interested in what we're doing, because we're all in this together. So thanks so much.